The third category of themes I'd like to talk about relate to decision making, and this is specifically once you've gone through the quantitative process of assessing clinical effectiveness as best you can and assessing cost effectiveness as best you can, how do you pull that together to actually make a decision? So how do you say, okay, this is clinically effective and it's cost effective, great, we say this treatment should be used. The first sub-theme here relates to the comparator. So if you're happy that you have a clinical effectiveness, good clinical effectiveness study compared with placebo and the treatment appears to work, and you're happy that you can develop a good cost effectiveness model that will give you an approximately, a good enough answer on cost effectiveness. The comparator of interest, the treatment that you should be comparing the new thing with, essentially should be current care. It should be the most appropriate comparator because we're interested in adding something to current care or replacing current care. So that's the thing that really we should be comparing with, not placebo. Now that was difficult because I've mentioned before now that practice was evolving really quickly, particularly in the early couple of years of the pandemic. So current care was changing a lot. And so at any given time, we could conduct an assessment and current care is out of date by the time we publish our findings. Partly that was because of a rapid entry of new interventions. So lots of treatments were being repurposed or tested for COVID-19, entering practice sometimes quite quickly, and even to the point where it wasn't just that the number of treatments being used in practice and in experimental settings was just increasing and increasing. Actually, in some cases, it went the other way when an experimental practice was found to not be very good and it stopped getting used. And the kind of big example of that is hydroxychloroquine use. So identifying the appropriate comparator to compare with in this flux situation where clinical practice and scientific understanding were changing so quickly was difficult. Some responses, some of our respondents advised or questioned that in the context of COVID-19 and a pandemic, is economic evaluation really the most useful tool anymore for HTA purposes? Now, as a health economist, personally, this was difficult to hear, but there were some valid points raised. So a really robust, thorough economic evaluation is often quite time consuming. You often need to wait for good clinical evidence to appear before you can start the process of developing an economic model and bringing in all those other things like resource use and quality of life. And that's not great in an urgent situation, a healthcare emergency where time was of the essence. There were also early in the pandemic quite a few relatively low cost interventions like corticosteroids, dexamethasone, that quickly appeared to be at least relatively effective for COVID-19. And so in the context of this emergency, there are some low cost things that could be introduced quite quickly. Why go through the time consuming process of understanding their value for money? Because if they help, they almost certainly are cost effective. The flip side to that argument is that the volume of use was potentially very high. So if that decision is wrong and that's not cost effective, it's potentially a big hit for health systems because of the number of people that would use it. Perhaps more pertinently, Francois, your question in the previous section kind of hit the nail on the head here. If the results of a cost effectiveness analysis and economic evaluation, if you know they're going to be very uncertain because of all the challenges, because of the uncertain clinical evidence, then what's the value in it? And that's where we ended up, I think, in the early days with organizations like ICER in the US changing their objective to being more about exploring what a good price might look like rather than trying to find the answer. Thirdly, in this theme, there were some question marks around what should the appropriate willingness to pay level or threshold be. Now, very briefly, the willingness to pay threshold, most health systems that use a health technology assessment process will have one. And this was reflected on health systems should be willing to pay more for effective treatments because they're willing to pay for better health outcomes. But if there's a fixed healthcare budget, then paying more for a new intervention, that money comes from somewhere else. So that money comes from somewhere else within the healthcare budget, within the healthcare system. Now, at a theoretical level, if we pay more for this new COVID treatment, because it appears to be effective, we're happy to pay more for it. That money is being taken away from potentially cancer treatments, potentially diabetes treatments, people with mental health conditions. That money is coming from somewhere. And so the kind of threshold, the willingness to pay threshold, is the amount that we're happy to pay for more health. Because we can't just spend an infinite amount on new interventions, because that money will come from somewhere. Now, a higher willingness to pay level means that as a health system, we're happy to pay a lot of money for effective treatments, and a lower level means that we will not pay so much money. The price needs to be lower for health gains. There were some reflections that might go up and down over the course of the pandemic. So early on, when there was no vaccine, unvaccinated populations, hospitals were full. There was few effective treatments. There was panic and societal issues, so the big societal burden. Maybe in those circumstances, the threshold should be very low. Should be very high, in that we're happy to pay for anything that looks effective because of the potential benefit and to get out of the urgent situation. And that might drop again. So the difficulty there is, over time, your decision making might become inconsistent. A year ago, we accepted this treatment with very small health gains because it was an urgent situation. Now what do we do about that treatment? Now we're out of the urgent situation. There are actually arguments that it should be high or low. So there might be government or policy incentives to quickly get any treatment that looks remotely effective out and in use. Or society might say, we really highly value anything that appears to help with this condition. So just pay for it and raise your threshold and be accepting of lower health outcomes or higher prices. And also, an argument there is that a higher threshold allows companies to charge a higher price. And just that fact might have incentivized more companies, to test repurposing their medicines for COVID, repurposing their antivirals and other drugs for COVID-19, if the potential financial gains were there of health systems being willing to pay more. On the flip side, lots of people got COVID. So the risk at a health system level of giving a treatment that actually turned out to not be very good, not very cost effective, or not very effective was high, because potentially so many people would get that treatment. And if you made the wrong decision, that's a big burden on the health system. That money is coming from somewhere. So one way to manage that risk and that high uncertainty is by lowering your threshold. So the financial burden on the health system is lower if companies have to charge a lower price to get in. And there are also some questions about, is COVID-19 really special? So taking it out of the context of a pandemic and a healthcare emergency, it's a respiratory disease infection. And is there really any reason that, away from the very urgent early stage of the pandemic, a year or two down the line now, we should be paying any more for effective treatments for that respiratory condition? We should treat that condition any differently to how we think about treatments for cancer, or how we think about treatments for a rare disease. So yeah, there were some sort of theoretical questions on, are we potentially, if we change our threshold and we accept, we're happy for companies to charge more for COVID treatments, what does that mean a bit further down the line? Is COVID really special? So these were discussions that were had.
And if I may, I don't know what the total healthcare expenditure was to purchase this these treatments and diagnostic tests and vaccines. But I have the impression that anyway, all healthcare systems had to find funds outside of their pre-assigned budget anyway, because it was a massive epidemic and a large part of the population was at risk. So, and in the EU, I think member states borrowed 450 billion euros, don't know exactly to whom, but to cover this cost and other costs. So I understand your explanation that within a certain budget, we need to decide on the willingness to pay, but here, in such exceptional circumstances, other budgets were used, at least in high-income countries, to cover the cost anyway. I understand. And by anyway, whatever the conclusion of the economic evaluation, and that may be what you will address in the political issues, that at the political level, a decision was made to anyway find the budget that was needed to cover the cost, whatever the cost, in the absence of time to properly negotiate the price of the various technologies in question.
Yeah, and you may have noticed that some of these sub-themes overlap quite considerably. And in the previous section, there were some comments around, is economic evaluation actually valuable in the context of the pandemic, given that that notion of fixed healthcare budgets has kind of gone while governments rapidly borrowed to address the pandemic, to address the urgent issue. And so that comes through here as well. Is a willingness to pay threshold, does it have any meaning when the context of the fixed healthcare budget has gone away? And perhaps not.